Started. You can
Okay.
start.
Good evening, good afternoon, good evening, wherever from the world people have connected. I would like to welcome all the panelists, Dr. Chandramouli, Dr. Avni, who are our colleagues at in headquarters and have done pioneer work in adolescent health and in violence against women, children, and adolescents. Dr. Zoya Ali, who is from the Ministry of Health, India, and who is the Deputy Commissioner and leading the work on adolescent health in India. I would like to first of all also welcome all of you to these webinar series, which we are doing collaboratively with Indian Institute of Public Health, Gandhinagar, Professor Dilip Mavlankar, who is the director of the institute. We are very, very privileged and fortunate to have this collaboration in the webinar series. There are 11 webinars under this series, which is promoting health throughout the life course during the COVID-19 pandemic. And we are already into the 6th webinar today, which is on COVID-19 pandemic challenges and opportunities for adolescent health, which will be moderated by my colleague, Dr. Rajesh Mehta. As you see from the list that we started with children, then had one on aging. Third one was again on adolescent health with a particular focus on pandemic impact and lockdown on adolescent health and well-being. And then followed by COVID during pregnancy, task sharing. As you know, that a lot of health workers are being repurposed for COVID-19. So how we manage the human resource, especially related to sexual reproductive health, access to contraception, access to safe abortion and post-abortion care. Today, we are going to focus on COVID-19 pandemic challenges and opportunities for adolescent health. And our eighth one later, will again be focused on promoting well-being of children and adolescents during the pandemic. So today, I think we are very fortunate to have expert and esteemed panel members with us to really talk about different topics. As you know, adolescents, although, in some countries now they are becoming the drivers of, pandemic by remaining asymptomatic, but going around and, coming back home with some infections. But then adolescents, whether because the schools are closed down, the universities are not open yet, they are at home, they are very, people full of energy, and during lockdown situations, and not even so much lockdown situations when the countries are opening up, we see that adolescents' needs are not properly addressed. Already, in many countries, adolescents were not paid much attention, especially when we talk about adolescent sexual and reproductive health. There are many countries of our region where adolescents get married early and they want to delay first pregnancy. So there the contraceptive needs are not met. There are a large number of adolescents who are sexually active and they are in need of contraceptives. So those needs need to be addressed both for adolescents. And when we say adolescents, I'm saying 10 to 19, 10 to 14 is early adolescents and 15 to 19 are late adolescents. And some countries have extended this definition to include, young people to up to 24 years of age. So these are the young people, adolescents who are in need of these services, but are we reaching them or not? We would like to learn today what are the needs and how and who is being reached with these services. Because we know across countries there is a disruption in essential health services. Countries are adopting some very innovative strategies on how to really, reduce the disruption and how to have a business continuity plan to be able to make sure that essential health services are not disrupted and the mortality as well as morbidity, is not high. So many countries have made wonderful gains during the past so many years, and they don't want those to be lost. So the second group of it, the second arm of it is domestic violence amongst adolescents, which will be addressed by Dr. Avni. Dr. Chandramouli will be talking first about adolescent contraception, and then lastly, it's very important to have experience from countries. And as these are Southeast Asia regional webinars, today we have selected India. Dr. Zoya Ali, who's the Deputy Commissioner, she'll be talking about repurposing activities of the National Adolescent Health Program for adolescents. So it's a going to be very exciting time for all of us, and very interesting webinar for all of us to really understand how India is addressing the needs, because India hosts the largest number of adolescents compared to the rest of the countries of our region. And India is, as always we say, is a young country. So given the largest number of cases also in India of COVID-19, India is really making, huge strides and response to address all these issues, which is to reduce the direct impact of COVID-19 and also indirect impact of COVID-19 on the essential health services. And today, our focus will be on adolescents. So with these words, I welcome all the panelists, esteemed panelists, our moderator, and Professor Dilip Mavlankar, who is our collaborator in this series, and his team, and all the participants who have registered so far. And I see we already have more than 250 people who are registered for this webinar. So I'll hand it over to Professor Dilip Mavlankar, Director, Indian Institute of Public Health, Gandhinagar, to say a few words, and then we move on to the moderator to conduct this session. Over to you, Professor Dilip.
Thank you very much, Dr. Neena. It is a privilege to work with WHO. The Indian Institute of Public Health, Gandhinagar, is a multidisciplinary public health institute, and since 2015, it is the first public health university of India, offering master's level programs in public health, as well as hospital management and occupation and industrial health diploma certificate courses. We are very happy that WHO Southeast Asia Regional Office selected us to partner with them to organize this series of webinars, and we are in the middle of the whole series. We have done half of them, and this is the next half is pending. We have had very enlightened and very informative series of talks and discussions on various topics related to COVID, and starting with child health, maternal health. Now we are in adolescent health. We also had a discussion on old age and COVID. And as all of us are experiencing this COVID epidemic, it is a turning point in many systems, including, we hope, our health systems. And adolescents, as Madam said, are the most sort of vivacious group in the whole society. They want to move out, and I'm sure they are homebound for this lockdown period, and they would, in some sense, in future, decide how to behave and how not to drive the epidemic there. In Gujarat, the most common thing which we are seeing is pan shops, which are full of young people and adolescents, and they get together there, and there has been a lot of discussion on how the behaviors need to change in many ways. Also, many services are disrupted, and we need to sort of restore the services as soon as possible. With that, let me again thank all the galaxy of speakers which are here from the Geneva office of WHO as well as from the ministry, and also welcome all the attendees for a delightful, I'm sure, series of very educative talks and discussion following the presentations. Thank you very much, Madam.
Thank you, Professor Dilip Mavlankar, for your kind words, and We look forward to this webinar, and I think I'll not come in between the panelists and the presentations. We get started. Over to you, Dr. Rajesh Mehta, who is our rich advisor for child and adolescent health, to moderate this session.
Thank you, Dr. Raina, and thank you, Dr. Dilip Mahalankar. Good morning, good afternoon, good evening to friends. There are more than 260 people connected today, and we have a galaxy of experts. So as our previous speakers were informing us, adolescents are a large number, and we recognize them as a vulnerable part of the population because of their age and their developmental status and attributes. They are considered vulnerable to several public health issues. And it is also well known from previous experiences that during disasters, during emergencies, during epidemics, their vulnerability increases because of multiple factors. And therefore, it is important to remember, as we were reminded by our previous speakers, that due to pandemic and lockdown, there were social isolations, there were closure of services like health, school services, and many times the nutritions are delivered in school, so midday meal programs are gone. The comprehensive sexuality education is also in many countries is delivered in schools, so that was interrupted. So there are a lot of issues around service delivery, not only in health but in school and in other community-based services. So that further has presented some challenges to adolescent health. So previous webinar, we focused on the overall health and well-being issues and school reopening, and we are considering another set of webinars, especially for education sector and health sector, bringing them together with UNESCO and UNICEF next month, so that we can discuss about school reopening issues and health and educational objectives that will happen next month. Today, we bring to you eminent experts to focus on adolescent sexual reproductive health issues and the domestic violence issues. We actually chose these issues, as Dr. Raina was saying, because these are little bit, these issues have not received much attention even in normal situations, and now is the time when it is further worsened. So it was a good idea to consider these sensitive areas once among our people in the region and outside, that how do we protect our adolescents during these challenging times. And therefore, we have chosen these two topics. There are many, but we chose these two for this webinar. And as Dr. Raina said, then India Program Officer, Dr. Zoya, will also share what India has done to mitigate the risks. So my pleasure to introduce the first speaker, Dr. Chandramouli. Dr. Venkatraman Chandramouli is an old known expert in this region on adolescent health. Presently, he is working for adolescent sexual reproductive health in WHO Geneva, and has been supporting countries in Asia and Africa and Americas on these issues. So he will be speaking on adolescent sexual reproductive health needs, including contraception during pandemic. So before he begins, I have a request to attendees. I see that there are now 276 of them. I encourage you to write your questions in the question answer box while the presentations are going on, and we will record your questions and then prioritize for doing a question answer session after the 3 presentations have been completed. Okay, so bear with us, write your questions in the question answer box, and we will pay attention to those questions. So Dr. Chandramouli, you may please start your presentation. I will let you know when 10 minutes have passed to plan your closing within time. Thank you so much. Dr. Chandramouli, please.
Thank you very much, Dr. Rajesh Mehta, and greetings from the World Health Organization's Department of Sexual and Reproductive Health and Research. In my presentation today, I'll be speaking about responding to the sexual and reproductive health needs of adolescents with a particular focus on contraception. The next slide, please. 25 years have passed since the International Conference on Population and Development. India, the other countries of Southeast Asia, such as Bangladesh, Nepal, Sri Lanka, Thailand, and others, have made enormous progress in this period. And the world of today is very different from the world of 1994. In terms of the demographic context, adolescents today are, there's the largest number of adolescents in the history of mankind. So adolescents are growing in a context when there are many more adolescents. They're growing in a context of increasing life expectancy. They're growing up in a context of decreasing poverty. They're growing up in a context of smaller families. Next slide, please. Adolescents are growing up in a very different social context as well. They're more likely to be digitally connected. They're more likely to be enrolled in school and to complete school. Although there are still some adolescents who are not in school and many adolescents who drop out of school early. They're growing up in a context of declining poverty. However, rates of unemployment and underemployment in young people are high, and as a result of the COVID-19 crisis, are increasing all over the world, particularly in this group. The next slide, please. Enormous progress has been made in some areas of adolescent sexual and reproductive health. As we catalogued in the Journal of Adolescent Health supplement, which reviews progress and sets out prospects. I'm just going to highlight 3 issues. Fewer girls are married before 18. The progress that has been made in India is phenomenal in this area. Fewer girls give birth before 18. The rates of HIV in adolescent boys and girls are beginning to decline. One notable area in which there's been very little progress is levels of intimate partner violence and sexual violence. That's something that my colleague Avni Amin is going to discuss in depth. This is clearly an important crisis. The next slide, please. This slide reinforces the point that, that averages mask disparities. And while we see progress in a number of areas of adolescent health, this also means that there are pockets of many countries where progress is limited, or in fact, things have actually worsened. The next slide, please. Shirin Gigi Boy was a WHO colleague. She now is based in India. She's an academic with enormous respect, and she published a blog piece, which you can see, the title of which you can see, which says that we cannot let the huge advances we have made thus far from being dissipated. So we have made progress. There's enormous progress to be made, and COVID-19 really threatens this progress. That's what is the focus of my presentation and the 2 presentations which follow. The next slide, please. WHO has published guidance on maintaining essential healthcare in the context of COVID-19, and these have been discussed in previous webinars in this series. If you don't have access to these documents, they will be part of the list of documents that will be disseminated after this webinar. So this is about maintaining essential health services in the health facility context and in the community context. Now, these 2 guidelines documents address all populations and all health issues. And they do address adolescents, but adolescent issues are kind of all over the place, and they are lost in the detail. And that's why, the next slide, please. We have worked with UNFPA to publish a set of technical briefs. This is a set of 7 technical briefs. 2 relate to my body, 3 relate to my life, and 2 relate to my world. Again, we will make these briefs available to anyone who's interested. The 2 that relate to my body are ones which have been developed by and with WHO. One is a question answer for adolescents and others, the lay public. And the second is a document called Not on Pause, responding to the sexual and reproductive health needs of adolescents in the context of the COVID-19 crisis. Practical guidance on what can be done, as I will show you. Next slide, please. Where do these not on pause is based on the 8 areas recommended for action by the Guttmacher Lancet Commission on Sexual and Reproductive Health. I won't read these 8 areas. I'll give you a couple of seconds to look at them. But again, we will make copies of the Lancet Guttmacher Commission report available to you. The next slide, please. In December last year, we published a set of 4 papers in the Journal of Adolescent Health, reviewing progress in the 25 years since the ICPD and looking ahead into the next 25 years. I mentioned that in the introduction to my presentation. Paper 3 is the package of health services. It takes the Lancet Guttmacher package and says, what does this mean for adolescents? And essentially what this says is ensuring that this package is available, accessible, and acceptable to adolescents requires an approach that looks at adolescents as biologically and socially distinct from other age groups and acknowledges that they face some barriers in obtaining sexual and reproductive health services. One big problem, and I'm Indian, so I can speak with intimate knowledge about the South Asian region, is the sexuality of adolescents, particularly premarital sexuality, is not acknowledged. It's almost as if it doesn't exist. And any discussion of it says this is foreign, these are foreign ideas, and these are foreign ideas brought to corrupt the local context. And that's not true. Many studies talk about premarital sexual activity in India. I'm 62 years old. I had sex before I was married. And I dare say that many of the people who are on this webinar have also done so. So I think we have to acknowledge this as a reality. Next slide, please. What we have done is it's very easy to put guidance out. What we have done is try to say what's being done in countries. And I started identifying promising initiatives to respond to the sexual and reproductive health needs of adolescents, which answer these 5 questions. And we've had them independently vetted by young people. And in this presentation, I'm going to share with you 4 of these case examples. We are producing a bank of case studies, and we look forward to you as participants in this webinar. If you know of a promising case study, reach out to us. We are trying to make this available to others. The next slide, please. One of the 8 areas that Not on Pause addresses is comprehensive sexuality education. It lists out 4 actions. The first action is communicate CSE messages through mass media and digital media. Next slide, please. And a wonderful example is this initiative called Education as a Vaccine from Nigeria. Education as a Vaccine is already written up as a success story, as a best practice in many documents. They already had in place a number of things. They had an SMS-based platform, they had a mobile application, and they had social media. But to respond to the COVID-19 crisis, they started putting out radio jingles and WhatsApp campaigns, and they retrained their counselors to provide information and counseling without discrimination. And what are they doing to determine if these modifications are working? They're using inbuilt analytics and getting direct feedback from young people. We now have a number of examples such as this. So programs are taking place. Next slide, please. I want to now focus on the heart of my presentation, which is responding to the contraceptive, counseling, and service needs of adolescents in the context of COVID-19.
Chandra, you have reached the 10 minutes stage, please.
Yeah, thank you very much. This contains 4 recommendations. Inform adolescents where and how to access contraceptive counseling and services, and ensure that adolescents can obtain these services in facilities. Consider establishing alternative delivery mechanisms, and consider setting up hotlines for adolescents to obtain services. The next slide, please. And a wonderful example comes from Ethiopia. Ethiopia is really a groundbreaker in adolescent contraception. So many lessons to learn from Ethiopia. Ethiopia, like many countries, was paralyzed during the emergency phase of the COVID-19 crisis. But immediately once things started opening up, Pathfinder has worked with the Ministry of Health to do two things, to set up a Telegram group. Now, Telegram, I discovered, is something like WhatsApp, but it means that large numbers of people can join this group. So they've set up Telegram groups for 4 regions with participation of about 1,000 people for information sharing. They've developed a guide to adolescent and youth development in the era of COVID-19, and they have reactivated health facilities. And now these facilities are providing contraceptive services to adolescents. They're getting the data from quarterly reports, from feedback from peer educators, and from the level of participation and data shared in the Telegram groups. This is happening, and this should start happening in the countries of Southeast Asia. Next slide, please. Another country which is hugely affected is the US. And this is an example from the Kaiser Permanente Hospital in Washington State in the US. So what did they do? They already had a range of adolescent services. So they started doing telecounseling services and made it easy to achieve telecounseling. Depending on the case, they started using video counseling, for example, to provide various options of contraceptives. If home management is not possible for the things listed there, then they set up an appointment with safety and bring them in and ensure that there's both visual and physical contact is safe. And then again, the data they know through follow-up calls and through online feedback. Next slide, please. A very innovative example from India is from Love Matters. Love Matters is India's largest digital SRH and rights information initiative. They've set up a WhatsApp chatbot service called Ranjana in Bihar. What it does is it answers adolescents' questions on contraception. It directs adolescents to the nearest clinic where they can get services delivered to the house. And what is being done, how they get information from focus group discussions and feedback on how this is working. Next slide, please. One important area that I need to stress is the need to work with the private sector. You know, government hospitals take time to reactivate private sectors there on the ground. These are examples from Nepal, from Kenya. Look at what the people in Kenya say. You know, among surveyed participants, 59% had obtained them from a pharmacy. Policymakers should recognize the role of pharmacies as contraception providers and look for opportunities to link pharmacies to the public health service delivery system. They are not an appendage. They are not a problem. In fact, they are providing more contraceptives to adolescents. When I needed contraceptives 40 years ago, 45 years ago, I went to a pharmacy. Next slide, please. To conclude, the Guttmacher Institute has just published a blog piece saying from bad to worse. It reinforced the point that Nina Raina made earlier. Young people in many low and middle income countries have experienced persistent inequities in SRH. Contraception rates in Bangladesh, for instance, are increasing in adults, but not in adolescents. That's true in India. That's true in many countries of our region, including for married adolescents. The potential negative effects are devastating, as listed in this slide. And it is crucial that policymakers see adolescents as crucial. It's no use talking about adolescents as our future strength and our future resource if you don't deal with violence against women and you don't deal with contraception. Next slide, please. This is my last slide. My last slide is that COVID-19 is a threat. It's an enormous threat, as Shirin Jijiboy said, as the Guttmacher Institute has said. But let's not pretend that everything was rosy and well for adolescents. Adolescents have been neglected in the context of MDGs, and here is an opportunity to build back better. And as I've shown you, many countries are already doing that. We don't need to sit for another 6 months to start then discovering the big crisis in adolescence. Over to you, Rajesh.
Thank you, Dr. Chandra, for keeping to your promised 15 minutes. And we are encouraged by 300 people who are listening to us. And I again request them to write their questions and answers so that we can prepare for a good question answer session in the end. So my pleasure to invite next the expert on domestic violence or interpersonal violence, Dr. Avni Amin, who works in WHO headquarters Geneva, to tell us about what and how to address it. Over to you, Dr. Avni Amin, in 15 minutes maximum. Thank you.
Thank you, Rajesh. I'm going to focus on three things in this 15 minutes. The first is just maybe talk a little bit about the public health burden of violence against women and girls, and specifically intimate partner violence or domestic violence. The second is discuss some of the pathways by which COVID has actually increased the risk of domestic and intimate partner violence. And then the third one is talk a little bit about what different stakeholders can do to respond to domestic violence, including some of the job aids and resources that we have available for everyone to use. Next slide, please. We know that we know from epidemiological data across many settings that while violence against women has multiple forms, intimate partner violence or domestic violence, that is physical, sexual, and psychological violence by a dating partner, by a husband, by a cohabiting partner, is the most common form of violence that is experienced by women as well as adolescent girls. Next slide, please. This is data globally that we have on estimates of violence against women, particularly intimate partner violence. And on the left side of the screen, what you see is the data, next, previous slide, please, is the figure 1 and 3, which speaks to 1 and 3 at 30%, 33, 35% of women who experience intimate partner violence as well as non-partner sexual violence across the globe. This varies by region, and the WHO Southeast Asia region is around 37.7%. And on the right-hand side of the graph of the slide, you see the data for lifetime physical or sexual violence by an intimate partner among girls 15 to 19. And you see that the bottom bar, which is for the WHO Southeast Asia region, is the highest. Around 42% of girls in the 15 to 19-year-old age group experiencing intimate partner or domestic violence. Next slide, please. We also know that sexual violence by any perpetrator is very widespread against children and adolescents. This is data from Sub-Saharan Africa of violence against children surveys, which show 5 countries, Kenya, Tanzania, Zimbabwe, Swaziland, and Haiti, where the rates of sexual violence against children and adolescents are well above 25%. We know that 120 million girls worldwide have experienced sexual abuse, but data also show that sexual abuse also occurs amongst boys, and the global estimates right now are 18% of girls experiencing sexual abuse and 8% of boys. Next slide, please. So the problem of domestic violence and sexual violence already existed and was quite widespread before the COVID pandemic hit. Previous slide, please. But what we know is that violence against women increases in all health emergencies, including epidemics. This is some data coming from countries pretty early on during the COVID pandemic of reported cases of domestic violence to police, to helplines, to hotlines in different countries. We have a longer list now from many countries, but just to give a few examples, for example, in the Hubei province of China, the police department reported a tripling of cases of domestic violence in February 2020 compared to the same year in 2019. Most of them were related to COVID lockdown. In the US, for example, domestic violence hotline was had influx of calls in which husbands and partners were using social distancing measures to further isolate their partners from resources and services. In the UK, in one of the counties, the police reported a 21% increase in domestic abuse incidents, in the previous 2 weeks, and this is much more compared to the year before in 2019. So these are just some examples, but I know that there are data coming from India, from different parts of the world. And there's just a long list of reported increase in domestic violence cases that are being reported. Next slide, please. So I'm going to talk about the likely pathways by which COVID has intensified the risks of abuse amongst those people who are already at high risk of violence. The previous slide. The first pathway is stress. I think the first thing is that as lockdown requires people to stay at home, families are spending more time in close contact. So the exposure to the abusers increased, the time of exposure to the abusers increased. The second pathway is the resources. Economic uncertainty has made resources more scarce, and this is really resulting for women and girls a higher risk for economic abuse. The disruption of livelihoods and economic activities has decreased access to basic needs, increasing stress, and this increases the potential for exacerbating conflicts as well as violence in the house. Perpetrators, we are getting reports of perpetrators restricting access to items such as soap and hand sanitizer. Perpetrators are exerting control by spreading misinformation about COVID and stigmatizing their partners. Next slide, please. The other pathway is the disruption in social and protective networks. Women and girls are bearing the increased brunt of care work, domestic responsibilities. With school closures, the burden on women and girls to assume the domestic responsibilities is much higher, placing more stress. They are having less contact with family and friends who could be supportive and could protect from violence. And perpetrators are using restrictions of COVID to exercise power and control to reduce access to services and help from both formal and informal networks. Next. There's also decreased access to essential services. The sexual and reproductive health services are becoming more limited. Services such as hotlines, crisis centers, shelters, legal aid, and protection services are being scaled back. A lot of shelters, for example, are being forced to reduce the number of people that they can admit. Conversely, as more and more women and girls are needing those shelters to escape very dangerous and unsafe conditions at home. Next slide. Next. So there are two resources that WHO has produced, which I'm going to, which I've provided the links to. One is a COVID-19 and violence against women, what the health sector can do guide. And another is addressing violence against children, women, and older people during COVID pandemic, some of the key actions. I've provided the links to both of them. And these are very practical tips for what can be done to address domestic violence during COVID. Next slide, please. Next slide. Taking from some of these guides, I just wanted to highlight that we have divided the practical tips into what the health systems can do. So that is specifically health workers and health administrators. And just to say, we have these infographics that we've taken from these guidance notes and also translated them into Hindi. So I've given the Hindi ones at the bottom. But really, it's basically suggesting that health workers should offer, according to WHO recommendations, first-line or psychological support, providing medical care, of course, and connecting the survivors who disclose violence to other referral services. For health administrators, the recommendation is to identify and share the names of all the referral services in your local area, to establish those linkages, and to find out what are the pathways by which you can connect people to these different services. Next slide. The first line support, we have a very practical job aid for all frontline responders. So this is health workers, hotlines and helplines. And in fact, we have a training package that WHO has developed, which we are now converting into an online format, which is called Lives or Listen with Empathy, Inquire About Needs, Offer a Validating Response, Enhancing Safety, and connecting the survivors to different social support services that they need. And above all, keeping in mind the safety, that is do no harm, and respecting the wishes of the survivor at the center. So Lives has now become the basis of training all frontline responders. And we, as I mentioned, are converting all of this into an online training for all frontline workers. Next. In terms of what governments can do, the guidance note that WHO has put out requests all governments to include violence against women services as essential to all essential package of COVID responses, and to actually finance and support and allocate resources for these services in COVID preparedness as well as recovery plans. Next slide, please. In terms of what communities can do as well as what perpetrators can do during COVID to reduce the risks of violence, the recommendation is really to ensure that humanitarian plans include COVID services, to gather data on reported cases, but to do so safely. Then community members, the guidance is around being aware of increased risks, to keep in touch with and support survivors in the family and social networks, to be aware of what information around what help is available, and above all, to be discreet in reaching out to survivors, because we also recognize that many survivors who are in lockdown don't have access to their own phones, or their phones are being monitored, which means that they may not have the possibility of safely reaching out to people for help, and to be prepared to call emergency services should a dangerous situation arise. For perpetrators, there's guidance around stress management to make sure that perpetrators can reach out to trusted friends and relatives to seek help, and to seek help from both health and specialized services, and to eliminate alcohol consumption. Next. And I have only 2 more slides. Next slide, please. In terms of tips for adolescents who are experiencing violence, there is an infographic around safety planning, which has specifically 2 sets of ideas around keeping a bag packed with emergency needs, ID, money, clothes, etc., so that if one has to leave the house on an urgent basis, one can, to be aware of and arrange with some neighbors or trusted adults, a code word, etc., to reach out for help, and to actually call any helplines and numbers that they may need to call for help on an emergency basis. For adolescents who are witnessing violence between parents, there is a Q&A which specifically asks adolescents to make sure that they have a trusted adult who they can reach out to, as well as if they witness an argument or a fight in the house, to not draw attention to themselves because the priority is safety, and to engage in a bunch of stress reduction exercises which acknowledge the fact that exposure to violence increases mental health conditions such as stress and anxiety, and including stress relief exercises, relaxation exercises, etc. And all of these tips, as I said, are available in both English and Hindi. Next slide, please. That's it. Over to you, Rajesh.
Yes, thank you, Dr. Avni. That was very efficient use of time. So I think my attendees would agree that previous 2 speakers have actually highlighted a lot of factors, multiple factors during pandemic which have affected the services. And actually some disruptions were inevitable during lockdowns, but the things are now opening up, and so are the services catching up. And we heard some very good practical examples of how to continue the services during these challenging times, because it is the rights of adolescents which we all have to meet. Therefore, it was a pleasure to hear from Chandra about education as vaccine for young people, an existing program, but now repurposed using a lot of digital platform and new content, because these new requirements are there. We also heard a telegram is an old phrase of my generation, but if some countries are using telegram groups, which are more like social media, I think those are very worthy of duplication and replication. Another important thing which I heard from Chandra was telecounseling is possible, but also it is important to do follow-up and also offer some contact or face-to-face services as and when required. So just telecounseling, converting everything to telecounseling may not be the answer. And then Avni has shared with us very practical, down-to-earth approach and messages, infographics. So those resources are available at WHO website, and Hindi translations are available. And we will wait if the region, other countries demand translation, we can help in translation so that these very good infographics and resources can be used widely. So I thank these two speakers, reminding my attendees, the audience once again, to write questions and answers. And my pleasure now to invite the third speaker, Dr. Zoya Rizvi, who is the Deputy Commissioner of Adolescent Health Program in Government of India, Ministry of Health and Family Welfare. So she will tell us about the RKSK, the National Adolescent Health Program, and how the pandemic has brought in challenges and what mitigation actions the government has taken forward to continue to serve the adolescents. Over to you, Dr. Zoya. Thank you.
Yeah. Thank you, Dr. Rajesh, and wonderful presentations by Dr. Chandra and Dr. Avni. It gives me immense pleasure to talk about what activities we are carrying out in India by repurposing under the National Adolescent Health Program. Next slide, please. Just to give a brief background as to the immense population we are looking at in India, 1/5 of our population, about 253 million, are adolescents. And these adolescents carry about 11%. The global data shows that 11% of the global disease burden is actually shared by these adolescents. However, the expenditure on them is merely 1.6% of the assistance which they get. And talking about comprehensive primary care, which is the backbone of universal health coverage, which we are looking at, we have a concept of health and wellness centers across India. We are looking to develop 1.5 lakh health and wellness centers, which will aim to provide the critical vehicle for reaching adolescents, whether in school or within communities. This is one program which is being strengthened in a big way in our country. And as last two data, you all are very well aware that investment in adolescent age group yields triple dividend, in which it reduces health expenditure in the future. It interrupts the intergenerational transmission of poor health, poverty, and discrimination. And also that every dollar spent on adolescent health, it gives a yield of 10-fold social and economic return. So the whatever investment we do in adolescent is going to yield far reaching efforts, and that is what we are working on in our country. Next slide, please. Just to give you, keep clicking, yes. Just to give you a brief, is that the National Adolescent Health Program was developed after a huge paradigm shift from an initial curative phase, which we have. Now we have gone into the promotive, preventive healthcare system. So there's a paradigm shift from cure to prevention and promotion, and the continuum of care approach, which deals with looking at the life and the life cycle approach. The health of adolescent is as important as the health of the mother, of the child, of the father, of the grandfather. This is like a whole continuum of care model which we follow in India. And of course, it is based on the huge convergent action. We are looking at convergence between multiple ministries which deal with the adolescent population, whether it is a Ministry of Health, of Education, of Legal Affairs, of Youth and Sports, about social justice. So we've got a lot of ministries which have interventions for adolescent, and we try and work together in our interventions in the field especially. And the 6 thematic areas which I've just put across are the main themes of our adolescent health population. As Dr. Rajesh also mentioned, these are the main things we are working on: is sexual reproductive health, nutrition, non-communicable diseases, injuries and violence, substance misuse, and mental health. So most of our interventions are actually targeted to prevent all these risk factors for adolescent. Next slide. So the key implementation approaches which India has developed are 3-pronged. We have got a facility-based approach in which we have set up adolescent-friendly health clinics at health institutions, government health institutions, as well as we are developing centers of excellence at district level. So this is the facilities government. Second is the community-based approach, and third is the school-based approaches. So through community and through schools, we are implementing a lot of programs parallelly. There is the weekly iron folic supplementation, in which weekly doses of IFA are given to children in school and in the community. Then there's the deworming bi-yearly in February and August. We have the deworming days in which all children are covered. Then there's provision of sanitary napkins in schools and out of schools. And fourth is a very critical component of our program, which is called the peer educator program, in which we have adolescent boys and girls between 10 and 19 who are selected to work as peer educators in the community or within schools, depending on what the state chooses. And these peer educators are trained to transact weekly sessions with their own peers. And in case of need of any help, they are supported by the ANM who's posted in that area. So kind of a whole comprehensive attitude towards healthcare of adolescents is being promoted. Besides this, the quarterly Adolescent Health Day, which you can see in community, this also is to create awareness in about adolescent within the community and schools. And of course, the adolescent friendly clubs, which are a village-based activities, which are supported again by ANMs. So we are looking at a multi-way of accessing adolescents within schools, through facility, through community, and of course through schools. Next slide. The next slide is just to give you all a brief of what is the progress in this RKSK, which is the Rashtriya Kishore Swasthya Karyagram, which is a kind of a mouthful, so I've just written the short form, which is the Adolescent Health Program. So in the clinics, just to go back, is our adolescent health clinics. We have more than 8,000 clinics across India. And last year we had a footfall of 7 million adolescent boys and girls who visited these clinics for issues related to the reproductive health or mental health or substance abuse, all the 6 thematic areas. But however, due to COVID lockdown here, now we have seen there's a huge fall. About 400,000 children only were able to access in the first quarter, which is from April to June. In the second component, weekly iron folic supplementation, this is covering boys and girls, whether in school or out of school. We are covering about 119 million children in this. And last year we covered about 35% of them. However, this year, due to the closure of schools and of the community centers called Anganwadi centers, we have covered about 5%. But now with the schools gradually reopening and the village centers opening, this percentage is going to go up very quickly. Third is the peer educator component, which I discussed. Of course, we have 340,000 peer educators who are working in more than 200 districts in our country, and more than half of them are trained. And the support in setting up, in having this quarterly Adolescent Health Day. Last year, we celebrated more than 15,000 Adolescent Health Days. So this awareness in the community is really increasing. However, this year, due to COVID, again, this Adolescent Health Day have been put on the back burner to ensure safety of our adolescents who are participating in these. And lastly, under the menstrual hygiene scheme, government is funding huge. We are funding 20 states. We have given 646.8 million rupees to these states, and now it is all in the ground. More than half of them have rolled the scheme into the ground, and we are covering more than 5 million children, girls who have been 50 million, adolescent girls are being covered last year, and this year the coverage is about 2.2 million. And now the whole strategy of covering this, which we'll discover next slide, the whole strategy of covering these adolescents through other activities, which I'll discuss now. This is, as was discussed initially in the previous presentation, also is the response to essential services, which I just want to emphasize this slide, is that initially right in March, we emphasized with the state that adolescent health service is a part of essential services. This was stressed again and again in all our reviews and all our discussion, that it was an essential service. And then the modalities, the way to access adolescents could be changed by the state, could be telehealth. There were modified outreach activities, there was teleconsultation, and there was also management of human resources. There were posted more to cover for adolescents, and of course supplies of IFA tablets, albendazole, and of course sanitary napkins was ensured. Next slide. This is just a snapshot of what major interventions we did during the COVID times, because as we mentioned, the adolescent health clinics are already there. But in the containment zone where there was high COVID incidents, in those containment zone, we promoted that the counselors who are posted at these centers continue with the telecounseling. So this telecounseling continued, and this has really brought out a lot of adolescents, as I think Avni mentioned also, in the injuries. So this kind of data is coming back to us, that mental health issue is a very critical issue on which the adolescents wanted to talk in the lockdown with the counselors. However, the adolescent friendly health clinics outside the containment zone continue to function, although I agree that the footfall was much lower, but the systems are coming back to normal gradually. And in the Adolescent Health Day, we had modified services. We tried to change the way the Adolescent Health Day was being organized. If you see this picture here, if you can somewhat see, it is a very hilly and a tribal area in Himachal Pradesh, one of the states in India, where they managed to have this Adolescent Health Day with adequate distancing, and they talked about COVID activities. They distributed masks and they showed hand washing. So it was a new way of actually carrying out adolescent related activities vis-a-vis COVID in the background. And while once we used to distribute IFA, albendazole and napkins in schools and in the village centers, now we have changed this whole strategy, and this distribution is being done within the community using the AAA platform. If you can see the ASHA, the Anganwadi worker and the NM3As who work within the community. So they're going from home to home, and whatever services they are providing, they're adding IFA tablet, albendazole and napkins for adolescent girls. So this is a different method which we are using now, and we're seeing good uptake of this because community is really aware about the health needs. And another issue which I want to bring forward is our civil society organizations, which are actually have good networks in the ground. So they are really supporting government in facilitating distribution of the above commodities. They are linking adolescents to the government services. They are also carrying on critical information, sharing especially COVID activities, COVID behaviors, and of course facilitating relief as well. So health actually has been supported by government. We have got good government program officers who are working round the clock in supporting adolescents, and of course our CSO partners who are also helping us. Next slide. This is just to give a brief about what are the main digital interventions which we are using in adolescent. First of them is iGot. iGot is a integrated government online training platform, which is a single point of access to a repository of training resources. This was developed by the government, by a department, and this is being hugely used. Many of our ministries are using it. For example, I just want to show as education, Dr. Mehta was saying we will have another webinar. Education is using this in a huge way. They've trained the teachers in the online method, and there are more than 10 million teachers and students are accessing training material, capacity building material, increasing their capacity and information while at home. So this is a big thing. Second, we also have an eSanjeevani OPD, which I have mentioned, which is a very good way of actually adolescents accessing health service because there's confidentiality is maintained. You book an appointment, the doctor comes online, and you discuss your issues online, and you get advice without actually sharing your age, or you may not share your age if you don't want to. So the confidentiality is maintained, and the doctor on the other side can also refer you where you need to go. Third is the helplines, which you already have is existing in many states. However, during this time, big states like Odisha, Kerala, and Madhya Pradesh, these are large states in our country, which have also used doctors and counselors from other programs, because these states realize that adolescents are facing a huge backlog and a huge mental stress issues are coming. So they utilize counselors and other health programs to counsel adolescents also. Just to get back adolescent health as an advocacy thing, we in Government of India have had regular review meetings with the state nodal officers to keep stressing on adolescent health with the states. Yes, and the web-based assessment of laboratory district, I want to just stress on this. We had a laboratory district concept in which all the components of adolescent health are being implemented in very hard to reach areas in backward districts, and we are supported by our partners like UNICEF, UNFPA, and WHO, who are going to show us what are the roadblocks for implementation and how we can improve. Lastly, which peer educator mobile apps which are already on the ground, but they are being used by some NGOs, as example was given by Chandra also, and we need further evaluation and cost benefit analysis to see if we can expand them. Digital platforms, of course, have helped adolescents in overcoming isolation, loneliness, and physical interaction, but I think all of us will agree that there's a huge digital divide. We do see that the boys access mobiles far more easily than to girls. Next slide. Just to give a brief about the school health. Next slide, please. Yeah. We have also had training of state nodal officers on adolescent mental health, just to stress that Government of India realizes that adolescent mental health is one of the critical issues. So we had this 2-day training of our program officers on fostering well-being and resilience among adolescents during and after COVID pandemic. So this kind of, it explained common mental health issues and then concerns whatever adolescents face. And it is also focusing on specific vulnerabilities of this adolescent this group, and also suggesting effective ways of promoting their well-being and resilience. So this was a very good uptake with all the states, and we are very happy with the outcome of this. Next slide. Now, in the background of this, we also have a school health and wellness, which is come in a big way. We are training 2 teachers per school this year, and all this training was supposed to be face to face, but with the COVID out, all our training schedule had to be changed, and now we are covering 200 districts as per target. We are covering, and we will be covering 110,000 schools, training 220,000 health and wellness ambassadors who are actually trained teachers and who will reach out to 20 million students. So this is a huge ambitious program, and we have already, next slide. We have already carried out this training of teachers in a virtual mode. Virtual mode training, as you can see, these are the 11 themes on which the teachers are being trained: the growing up healthy, emotional well-being, relationships, values, citizenship, gender equality. Like this, all these 11 themes are there, and these are continuous interaction. We have already trained about 22 states. We have 36 states and union territories in India. So we have trained already 1,300 members by virtual platform over 4 days in all these themes, and we have used more than 40 national experts who have done this. We are also conducting pre and post questionnaire to assess their knowledge. So this is really helping, and this is all done virtually, and a lot of innovations have come across the way we have interacted, the way our sessions are held, group sessions, videos are shared, and discussions are held. So this is something which government has done, and it's strengthening the education with teachers and accessing children eventually. Next slide. Yeah, these are the advocacy material which again has been developed with school health as per the 11 themes and has been shared for e-distribution. So all thing is being web-based so that there is no physical safety at risk. So these are being distributed to teachers, to principals, and eventually to children to create more awareness about health and adolescent health issues which they face. These are just 3 posters for examples. We have got more than 11 which we have shared as per the theme areas. Next. I think the next one is the next, please. Yeah, this is the last slide. This is such a beautiful thing. This is our northeast state, Arunachal, and this is in the district Namsai, which is right at the periphery. And here too, they are actually, after lockdown, they're also having Adolescent Health Day, in which awareness of COVID activities, how to keep yourself safe, everything is done in the community. And you can see our health workers as well as the adolescents who are, I think, very proudly showing that they're actually working on adolescent health. That's all for me. Thank you. Back to you, Rajesh. Yeah.
Thank you, Dr. Zoya. So we heard from a big program like the RKSK or the Adolescent Health Program in India, and we are happy that 10 countries in our region actually are implementing national adolescent health programs, and all of them have various experiences. Today we had opportunity to listen from India that a lot of digital mechanisms have been used to modify the existing services so that the work continues both for training as well as for service delivery. Some digital options have been used. So very encouraging that countries have mitigation strategies to understand this. So thank you all the 3 panelists. We have some questions already with us, which we will start addressing. In the meanwhile, if people can write some questions for Zoya's presentation, we will also want to accommodate that. So let me start. There is a question directly about what is the status of contraceptive use of adolescents in India. So Chandra, do you want to address that, or do you want me to say something?
Okay, I can speak. In India, the data we generate, if you talk about contraception, is for the register, which is called the eligible couple register, in which whenever a couple gets married and comes to the village, they have to get registered in the village as eligible couple, and that is where the data is generated from. So if you look at adolescent per se, I would say we don't really have the data for adolescent unless they're married.
Okay.
Could I add to that, Rajesh?
Yeah, Chandra.
What did we say? Yeah.
So I thank you for that question. I have 3 points to add to what Dr. Zoya Rizvi said. One is, if you look at NFHS, and if you look at the progress in NFHS, which is a national survey, the National Family Health Survey, which is conducted in India by the government with the involvement of the government. In the NFHS 4, the most recent one, among 20 to 24-year-old women, the 23% of them used a modern method of contraception. That's still very low, even when you compare with other countries in Southeast Asia. But in adolescents, it was only 10%, 15 to 19. Now we are talking about married women. That's what the data for NFHS talks about. That's the first point. The second point is, if you look at zero parity, that means women before having a child, or one parity, that means one child, rates are very low, 2%, 3%. So what's still the practice in India is many, I'm not talking of upper middle class people who buy it because they are still a small proportion. Many people in the poorer parts of the country are having 2 or 3 children and then starting to use contraception. And that's really a big problem. The third point, and this is the last point, from Population Council survey in Uttar Pradesh and Bihar, premarital sexual activity by the age of 18 in boys is about 25%, and in girls is about 8%. And of course, these data don't come into government systems because they never come to government facilities for health services, especially contraceptive services. Over to you.
Thank you. Yeah, thank you, Chandra. So there is some disaggregated data on unmet needs also for 15 to 19 in India as well. But the Chandra's point that the unmet needs are high is valid across many countries in this region. India is not the only example, but India data was asked. So another data point is that between NFHS 3, which was 2005, the unmet need was around 40% among 15 to 19. And in 2015, or 10 years later, it was reduced to 27%, the unmet needs. Okay, so that's a reflection that there is progress, but compared to the older age group, this unmet need is much higher. So that must be remembered, that adolescents are experiencing sexual intercourse, but the unmet needs of contraception are high, which exposes them to both pregnancy and infections. So that's a valid observation. So going to the
one additional point about unmet need, Rajesh, because we shouldn't take these terms just for granted. Unmet need means what? That means a woman who wants to avoid contraception is not able to get contraception. But we know very well, and being an Indian, I know that this is so true in my own family, is as soon as a girl is married, she's under pressure to have a child. What we say is they're supposed to be asexual till they are married. Everyone talks of them as pure like a white flower. They're supposed to be fully sexual on the day of their marriage. It's still in many communities to show blood on the bed sheet, and they're supposed to show a male child in 1 year. So there's a huge pressure to have children. So unmet need will only decrease when women can decide when to have a child or if to have a child.
So there are data points which are useful and then must be interpreted correctly. And Chandra, moving from there, what are the effective strategies to reduce the unmet needs? This is another question.
Yeah, Dr. Rajesh, can I just comment on what Dr. Chandra said about the children deciding about when to have a child or not?
Oh, quickly, then, because I have 3-4 more questions to you.
Quickly, just 2 minutes I'll say is that is what we're looking at in implementation of the school health program and training teachers. That's what we're telling them, that the huge concept of consent and being mentally, physically ready to have children should be stressed when you talk to school children. That is when they get married, a child within 1 year is not really necessary. So that is the kind of discussion which we're having with teachers, and I'm very happy to say that's what's happening every time. These last sessions which you're having, we are stressing again and again that, okay, get married, but don't have a child unless you understand each other for a couple of years and then decide when you want to have a child. So that is something which you're discussing with teachers in a big way.
I cannot reinforce the importance of that. The Indian Prime Minister has talked on important public health occasions about violence against girls. He's talked about responding to the menstrual hygiene needs of girls. And these kinds of issues are issues that we have to talk about. And as I said in my earlier comments, child marriage rates have declined. Progress is there. Important progress is being made, but much more needs to be done, both in terms of not being pressurized to have a child and in what Avni is going to talk about, which is about consent. When a woman or a girl says, no, I don't want to have sex, that is respected. even if it is within marriage. But coming to your question, Rajesh.
So Chandra, there are two questions for you. One is how to reduce the unmet need generally. Then second is during lockdown when mobility was restricted and they are being closely monitored by family members, what are the additional ways to improve access?
Very good. Thank you, Rajesh. Now, the answers to this are there in the Not on Pause document. It sets out 8 practical recommendations for countries to use, and I've illustrated that with some examples. But let me reinforce. The first thing is adolescents must be informed where they can get contraceptives. And you can do it in a non-controversial way. You don't need to talk about married or unmarried. We can just talk about it in the context that, you know, if you want contraceptives, this is where you can get them. We see on buses, they talk about emergency contraception and medical abortion, and so this can be done. That's point number one. Second is in health facilities, it's important that contraceptives and a whole range of contraceptives are available. I showed you the example of Ethiopia. They have a whole basket of contraceptives available. The third is, even if a woman is accompanied, and in the times of COVID, if accompanied by another family member, then we cannot assume that that family member knows that the adolescent wants contraception. So it should be very discreet in any discussion with the adolescent on contraception. The other point is, so one is health facilities are key. In a huge countries of our region, we cannot rely only on private sector and NGOs. Government facilities have a key role to play. Second is hotline. I gave you the example from Washington State in the US, where hotlines are increasingly used, and they're beginning to be used even in other low and middle income countries. And the third point is we have to work with the private sector. We have to work with community-based distribution. Most boys get condoms from outside clinics. So those are the 3 approaches which particularly reinforce the importance of discretion in the context of COVID. Over to you, Rajesh.
So thank you, excellent points. And then we have to recognize this sensitivity around anonymity, and therefore vending machines, hotlines, well-publicized pharmacies and government facilities where these are available, not during COVID, but normal circumstances also. These are common ideas which can be scaled up. And in COVID days, especially, you have to innovate further through social marketing and other approaches. Like peons and postmen have been used to supply essential medicines. So one could also consider several new channels of service delivery. So there is one more question which must be addressed before we close. Avni, there is a lot of sexual abuse which is potentially possible, and more during this COVID pandemic. And we have heard that boys can also suffer. So the question is that how do you overall reduce sexual abuse, and what about boys as victims of sexual abuse? Avni.
So overall, I think it's a longer term issue of really building in the norm around consent, which requires a comprehensive sexuality education as well as messaging around consent in sex. So I think that needs to happen, and during COVID, this needs to be accelerated as a message. Whether it's done through WhatsApp messages, campaigns, online campaigns aimed at adolescents, or through sites like Love Matters, I think that really needs to come through.
So for both proactive approaches, great.
Yeah, proactive. Then there is the issue of responding to those who are already who are experiencing or have experienced sexual abuse, that is boys and girls. One of the biggest barriers for both boys as well as girls is the stigma and shame. So it really tackling this issue of the silencing and the stigmatization of survivors, both boys and girls. And I think that really needs to also go out as a social campaign, that survivors should not be made to feel stigmatized. It's not the survivor's fault for having experienced sexual abuse. So that can help in them coming forward. The third thing is all of the big adult stakeholders who come regularly in contact with adolescents. This includes health workers, it includes schools, it may include sports coaches and mentors. It can, it can include a range of adults who come regularly in contact to be aware of the signs and symptoms of sexual abuse, to be trained on how to ask and how to then link them to services that sexually abused survivors need. So that is the third sort of approach. The fourth approach is really staffing and resourcing, including during COVID, the helplines, the hotlines, the child helplines, the child counseling services to handle and field calls from survivors of sexual abuse who might come forward, which is usually a smaller number of sexually abused girls and boys especially, because they feel that their masculinity will be called into question if they come forward and report that they are being sexually abused. So to really proactively fund these services. The fourth is mental health services to be resourced so that psychological support and mental health services can be offered to children who are experiencing sexual abuse. And the fifth, which is a longer term preventive measure which has impact on many things and not just sexual abuse, is reductions in alcohol sales. And a lot of countries actually, and including I think in India, South Africa did the same, Australia did the same, that during the lockdown, they really reduced alcohol sales and outlets and hours as one of the triggering factors for abuse.
Okay. Yeah. So thank you. There is an array of approaches which can be used to prevent and manage. So thank you for sharing that. One last question, and then we will close. Chandra and there is a question around role of parents. How can we use parents in influencing adolescent behaviors and services? Chandra, it says specifically about adolescent contraception. What is the parents' role and how can they be engaged? And Zoya, if you can tell us in RK Escape, there is a parenting component. Chandra first.
Thank you. I mean, there are wonderful questions in the list that we are seeing. And what we promise you is every single question we will respond so that we give you summarized responses which can be posted afterwards. The WHO has published a document on the role of parents, and we will make that also available. Parents have 5 roles. One is to give love, unconditional love to the child or adolescent. Second is to negotiate and apply limits so that love comes with limits. The third one is to role model good behavior so that you can't talk about, respecting women when you don't respect your wife or you don't respect your sister. The fourth one is protecting and providing. And the fifth one is the one that is particularly important in relation to contraception, is recognize evolving capacity. A child of 2 is very different from a child of 9, which is very different from a child of 16. And one important point is our parents slowly have to accept that adolescents are sexual beings. They can close their eyes, they can ignore it, but the reality is adolescents are sexual beings. And if we don't talk about it, Nina Raina is a great hero in this. She has a son. She's talked in many meetings about how she talked to her son about menstruation, how she talked to her son about his sexual needs. And those are important things to talk about. If kids will quickly recognize if parents can't talk. I never talked to any of this with my parents. But I've told my son, I had sex before I was married. I have no problem if you have sex before you are married, but please be safe, both physically, but also emotionally, both with yourself and with your partner. Rajesh, I'd like to mention that we are putting on an e-course with UNFPA and FP 2020. It's open for everyone. We will announce the details of the course. Over to you.
Zoya, please, and then we hand over to Dr. Van.
Yeah, I did not hear what Chandra said because in the, I think 2 minutes into it, it just became mute for me. Okay. But I would just like to say under RKSK, yeah, but it's good I didn't hear, otherwise my answer will be very biased. But I think he covered everything. He covered all the role of parents and all the role what how parents can help. That's very nice. Under Rashtriya Kishore Swasthya Karyakram Adolescent Health Program, we have realized that parents have an equal part in educating their children, informing the children. So we are holding, with support of course WHO and a local Center of Excellence in Delhi, we are having these parenting awareness workshops. We are having sessions which are involving, of course, other medical officers, other doctors who are dealing with parents, as well as it is open for parents as well. So this awareness has come. I think initially we stuck with the medical profession for providing services, but now we realize that medical can do only so much. Involving parents is actually has far reaching and far longer reaching effects in improving adolescent health vis-a-vis just healthcare. I agree with what you said. Of course, whatever I heard of Chandra was so nice. Unconditional love and setting limits and providing information. I'm all for it. Thank you so much. Yeah.
Okay. Thanks a lot. So thank you, Dr. Chandra, Dr. Avni, and Dr. Zoya, and the attendees of this webinar. My pleasure to hand it over back to Dr. Neena Raina for closing. Thank you.
Thank you very much. I think it's always lovely to hear the three panelists who have been so close to my heart, and I think they are the pioneers. Thank you, Dr. Chandra, Dr. Avni, and Dr. Zoya. I think a wonderful work is being done. I'll summarize and put 4 questions or 4 summaries, 4 areas to focus on. I would say comprehensive sexuality education is something very, very important. Different countries have been toying with the idea because the word sexuality really brings a lot of people into saying that no, this is something which is not good for our society. So we need to find a better word for sexuality to be able to get knowledge to the adolescents, which Dr. Chandra highlighted very well. So, knowledge is power. Sex is a choice for adolescents, and contraceptives is a need. And I think either as program managers or experts or parents, in whatever capacity, or private sector, in whatever capacity we work, it's very important for us to understand that we give them knowledge, let them, decide whether they want to have premarital sex or not. I think as gatekeepers, whether it's communities or parents, within the societal norms, we bring up our children and give them values. And it's their choice what they want to do. And none of us should be judgmental in deciding whether what they are doing is right or wrong. I think importantly, we have to make sure that if they choose to have premarital sex, we must make sure that they are safe. So I think that's one clear message which is coming out for us, to be really having supportive laws and policy environment to be able to give access to those who ask for it, and not really brush it aside and be judgmental about it. And involvement of private sector, as Dr. Chandra said, is extremely important. The second message I want to bring in, because adolescent is one area of work where a gender construct plays a very, very important role. And gender construct doesn't start when they are adolescent. It starts when a boy or a girl is born in a home, and that is the time. You must have seen, the way, when the baby is small, started going to school, everybody says, oh, do you have a girl? Or you like in your class, you have a girlfriend. But from their daughter, they'll never say, do you have a boyfriend? Or do you have a boy whom you like? So the construct, and as I think was said earlier, that what the parents do, the way they talk, gender construct emerges, and that leads to domestic violence or intimate partner violence, starting, from home. So they learn all these things. So I see that violence against women, children, adolescents is very much a health subject. And when you go to the ministries of health, they said, sorry, we have nothing much to do with it. Dr. Zoya, you should not be focusing on violence against adolescents. Tell me, as a program manager, why violence against women or gender-based violence should be with the Ministry of Women and Child Development? And I think it is very, very important that the health sector takes a lead. And I'm reminding myself when I started with adolescent health program through WHO in Sero in 1998. And I said ministries of health should be in the driver's seat to address adolescent health. And I'm very happy to see that how far this journey we have come, to see that adolescent health is now embedded in the every Ministry of Health program in our region. So I'm saying again, I'm challenging all the ministries of health, why violence against women, children, adolescents should not be part of Ministry of Health, because it is their mental, physical, emotional health which gets impacted the most. And health workers are the first point of contact that they come to. And I see ministries of health invariably are very, very silent. And they take ages to really come forward, to really use the materials which Dr. Avni has said. And Dr. Avni, your experience and pilot which you have done in Maharashtra as WHO is pending approvals. We are saying let's disseminate this to larger number of health workers, to the frontline health workers, build their capacities to be able to really provide support to these women, either through teleconsultations or otherwise. So that's my second clear message and a big request to everyone who's connected and to the ministries of health. And India can show the path to the rest of the countries, and I feel, Dr. Zoya, I hand it over to you as a responsibility to take it forward and really address it in a big way. And my last point, which I'm coming to, is that when we talk about services, we really need to really focus on the most vulnerable ones. And the most vulnerable ones, those who are out of school. Because of COVID-19, there are a lot of young adolescents who were in informal sector employments. They have lost their jobs. They have nothing to fall back upon. So we need to really focus on their needs as well. And there is adolescent sexual reproductive health assessment tool which we developed. Bhutan, Bangladesh, Nepal, these are the 3 countries which have done assessments on adolescent sexual reproductive health. And India, I would say that tool is ready, Dr. Zoya. You can contact WHO country office focal point, Dr. Kiran Sharma, and you can just use that. And India is doing so much. And this is the opportunity that you use this tool, document it, publish it, and let other countries know what good work is being done in India. So I think these are opportunities. So I see that there is a lot which needs to be done, a lot which has been done. We have come very far. And I think we have come this far only because we had champions like you people, especially the 3 who are sitting here as our panelists, who are so emotional about it. And also Dr. Mehta, who is whom we got into country office, India first, and now he's working in my team in the regional office. I think it's very important for us to be passionate about it. They are our future generations. It's not enough, and as Dr. Chandra said, it's not enough to say that they are our future. Let's do something. But it's very, very important for us to really deliver, to change, and not get bogged down by the challenges which many of the countries face, ministries of health also face, private sector faces, we all face. So I think challenges are bound to be there. They are there in every program. So how can we really strengthen? And corporal punishment is one wonderful example where we all have been beaten up in our schools. The teachers won't even think twice. They won't blink an eye and just give us a slap at the back or on our face or on our head. But look at today, in the schools, whether they are government schools or the private school, because of this, the thrashing, which the children in the schools used to get, the teachers are scared, the teachers are careful. How? And how can we bring in media for positive messaging and not really bring in negative messaging? And I think politicians, religious leaders, communities, parents groups, NGOs, private sector, everyone has a big role to play. And let's get them together. Let's put them as one network and support contraceptive access, as well as let's end the violence against women and children, and especially the sexual abuse, which happens early in age. And there are many, many examples and many stories which are heartbreaking. With these words, I would like to thank Dr. Chandramouli, Dr. Avni, and Dr. Zoya for really bringing up wonderful issues on the forefront. This is, one area which is very, very close to my heart. Dr. Chandra said I went through this, the sexuality education, menstruation, everything with my son, who's 28, who himself is a doctor now, and he's spreading it to others. But I think this journey was tough. When the man in the house is not ready to talk to the boy, but you have to do it. So I think, but then every mother has to do it, irrespective. And as parents, we have to play that role. So with these words, and I'd like to thank Dr. Rajesh Mehta for being the moderator, and also, keeping this fire burning of taking the torch ahead on adolescent health, and all the people who have linked today, all the participants for being with us till now. And my special thanks are to Dr. Professor Dilip Mavlankar and his team, especially Kalpana, who have done a wonderful job of letting us have this webinar without any glitch. Thank you very much. Have a safe, I wouldn't say flight, because I'm looking forward to the flights when we can travel and we can go and see these programs in different countries. But I think this shall pass. So during the COVID times, stay safe with your families. And thank you very much once again. Thank you.
Yeah, thank you.
Thank you all. And if you send a message, we will respond. Please write.
Yes. Thank you. Thank you.
Thank you.
Yeah, thanks to all the state people who are here. Over here. Yeah, thanks.
Yeah, I see a lot of people are still there. Thank you. Bye.
Yes.
Good to see you, Chandraji and Dr. Avni.
Thank you, everyone.
Thank you.
Yeah.
Stay safe, stay healthy. Bye-bye.
Bye. Because
Bye,
I see in the ministry, there are a lot of people who are, quarantined because of this.
Yes.
Dr. Zoya, please stay safe. Huh?
Yes,
Okay.
thank you. Thanks for your wishes. Yeah, thank you. Yeah, bye.